So hello everyone, and welcome back to our Young ESPGHAN webinar series. We will just wait a bit for more people to join, and we will start with our introduction about Young ESPGHAN, and then we will go further to our presentation today. So as you might know by now, my name is Mara Ionescu, and I'm a member of the Young ESPGHAN committee. And today we are going to talk about a very interesting topic. We are going to talk about the low FODMAP diet and unlocking relief for irritable bowel syndrome in children. We have today a great speaker, and this is Lucy Jackman. So I will start with our short introduction about our Young ESPGHAN committee. I hope my presentation will actually work. Okay, so who we are and what do we do? We promote high quality research and training for our young trainees. We organize different activities for our young ESPGHAN members, but most important, we represent their interest within the council and the society. Regarding some of our educational events, each year we organize the Young ESPGHAN Mentorship Program, which is a forum to meet and receive support from more senior ESPGHAN members. And this has been going on since 2017, and last year we had 12 pairs. This year, of course, we had another edition, and the groups they are going to meet during the annual conference in Lille this year. Regarding last year Young ESPGHAN Day, during each annual conference, we have Young ESPGHAN Day, and last year it was on Wednesday, and we had a very interesting topic regarding decoding research, systematic reviews, meta-analysis and peer review essentials, and also we finished with a reviewers program. Also, we had a very great session regarding immersive painting, and we can see in this picture that we had great fun. Also, last year during the annual meeting, we also had a Saturday session, and we talked about navigating clinical cases for young professionals. And always during the annual meeting, we have the Meet the President Day. Last year, we had a meeting with the former and the actual president. And this year, I just want to advertise again that we have very interesting topics. During Wednesday, during the Young ESPGHAN workshop, we are going to talk about data analysis and statistics. And it's a great opportunity for you to learn more about this, because we know that sometimes this part can be a bit tricky. And also during the Saturday session, we are going to talk about the guidelines. We are going to talk about IBD, about vegan diet and nutritional status in children. And also we are going to talk about Wilson disease guidelines. So please join both of our sessions. Regarding other upcoming educational events besides the annual meeting, we have the nutrition summer school, GI summer school, night masterclass, and also if you want to learn more and see all about the courses, please go on our website and click on the courses button. But who is the team of the Young ESPGHAN committee? We have Anne-Marie, who is our chair. We have Angelis, who is our secretary. Petra, who is our treasurer. Francesca, who is our social media guru. Pinar, who is our international affairs officer. You have myself, Mara. We have Jose, Giovanna, Harwin, and Beno, who are JIC Nutrition and HEPCOM representatives. But probably next month we are going to have a bit of a different group, because there are some new members that are going to join us. So if you're not a member of the Young ESPGHAN, please try to register. You have many benefits, from subscription to JPGN online, to access to different research grants, awards, access to the Young ESPGHAN committee, and many other events, possibilities to take part to many other educational events. So how to become a member? You need to fill in the application form on the website. You need a CV and a letter of support from a full member that is not serving in the council. And also, if you want to stay connected with Young EVSGHAN, just please follow us, stay connected. You can do that on Instagram. You have here a QR code, scan it, and just join us on the Instagram to find out more about Young EVSGHAN committee and our events. Also, I would like to end this presentation with a very interesting survey we are now conducting about pediatric gastroenterology, hepatology, and nutrition training across whole Europe. Please scan the QR code, share your experience, because your experience is extremely valuable, because we can actually build better training based on that. So you have like 1 month to fill this survey. It takes less than 10 minutes. So please just take a moment, scan the QR code, and whenever you have time, just please fill in this survey. Regarding our webinars, we have exciting new topics. Next month, we are going to talk about emerging therapies in IBD, what's next for treatment. In August, we are going to talk about autoimmune hepatitis, and also we are going to talk about basic and advanced endoscopic techniques, and of course, the ROM 5 criteria. I think you are all waiting for this. So please join us for the upcoming Young EVSGHAN webinars. So without further ado, it's my pleasure to introduce Lucy Jackman, who is a pediatric dietitian based in UK at the Great Ormond Street Hospital in London. She is the lead dietitian for neurogastroenterology, motility disorders, and complex gastrointestinal allergies. As part of her role, she runs a dietitian-led FODMAP service to support children with DGBIs. So it's our great pleasure, and thank you very much for accepting our invitation. And please enlighten us regarding the low FODMAP diet in IBS in children. Thank you very much.
Thank you so much. I think I just need to share my slides and then we're good to go. Okay, so just checking that's on the right screen. Yes. So thank you for that, Mara, and thank you everyone for joining me probably for your last hour of the day. So like I was introduced, my name's Lucy and I'm a pediatric dietitian in London at Great Ormond Street. So obviously I'm going to be talking about the low FODMAP diet and actually diet in general in IBS in pediatrics. So why is it important? So we all work in gastroenterology or any clinic in pediatrics. We know that we see a whole host of different functional GI conditions or disorders of the gut-brain interaction, as they're kind of now termed. So that's abdominal pain, it might be flatulence, bloating, altered bowel habits, so constipation and diarrhea. And actually this has a really big impact on our workload. With constipation and abdominal pain being probably the most common types of sort of functional conditions that we see. And it's reported around a 14% prevalence of abdominal pain related to disorders of the gut-brain interaction, and around about 5% of those being classified as IBS, so in children age 4 to 18 years. And you know, this is quite a high number within our sort of clinics, but actually it's not just the impact that this has kind of on the symptoms that the children experience, but actually on their significant impact on their quality of life. So their daily functioning is often impacted. School attendance is usually a really big issue with children with disorders of the gut-brain interaction. Lots of families struggle to go on holiday or choose a holiday close to home, so they're not having to go on long flights, etc. And you know, the relationship with food can also be impacted. And we know that there's a considerable overlap between IBS and sort of functional abdominal pain as well. And trying to work out the difference between those can sometimes be a little bit challenging. So what symptoms are we looking for? So, I mean, these are symptoms that we see in a vast majority of pediatric gastroenterology issues. So we've got abdominal pain, constipation, diarrhea, bloating, cramping, or you might have this mixed picture between constipation and diarrhea. And actually, patients with IBS report more food-triggered symptoms than a child without IBS. And it's around 50% that feel that they have improvement in their symptoms with dietary eliminations. So many of these children might come to clinic already on eliminations, or it might be a technique that we can use as clinicians to help improve some of those symptoms that they're experiencing. But how do we diagnose IBS? So I suppose we need to think about what other conditions those symptoms might present as. And as I've already said, lots of these symptoms are prevalent in other GI conditions. So in GERD or GI allergy, delayed food allergies in general, IBD, pancreatic insufficiency, disaccharidase deficiency, SIBO. So a whole host of other conditions can also present with these symptoms. Of course, there's some red flags that we know as clinicians that might make us think this is more of a biological condition rather than a disorder of the gut-brain interaction. So, for example, mouth ulcers or more of a systemic involvement to the systems, if there's lots of blood or excessive mucus in the stools, and other red flag symptoms like dysphagia, which could suggest a condition like eosinophilic esophagitis. So at the moment, we don't have any biomarkers that we can use to diagnose IBS. There was actually a paper published last year that looked at using a panel of IgG blood tests to guide an elimination diet for patients with IBS. And this wasn't like a York test that, we see brought to us on a piece of paper in clinic. It was very specifically designed, a tailor-made IgG panel that was used in these IBS patients. And what they found is that the patients who had the elimination diet guided by these IgGs had a better symptom response. But I think it's still quite early days for that, and it's not something that we would all be using in practice at the moment. It's just in the research setting. So at the moment, our diagnosis is based on kind of ruling out that there's no biological reason for these symptoms and going on the clinical history. And actually, Mara already mentioned the Rome-5 criteria, which is obviously recently published. And there has been some changes around IBS diagnosis within that sort of guidelines. And so you can see the list here of kind of top 6 symptoms or diagnostic criteria for IBS in pediatrics. One of the big changes that we're seeing in the Rome-5 criteria is actually moving away from these symptoms having to be present for sort of 6 months before that diagnosis can be made. And it's actually a much shorter period. So only an 8-week period where these symptoms have to be ongoing and sort of prevalent for that diagnosis of disorders of the gut-brain interaction and IBS to be diagnosed. So within IBS, we've got kind of 4 subcategories. You've got your IBS-C, so that's constipation dominant. You've got your IBS-D, which is diarrhea. IBS-M, so a mixed bowel picture, so between constipation and diarrhea or a combination of both of these. And then your IBS-U, which doesn't really kind of fit into any of those subcategorizations. I've mentioned that IBS is a disorder of the gut-brain interaction, or a functional GI condition, as previously it was called. And we know that the gut and the brain are inherent and intrinsically linked. So this is a bidirectional manner, which means that they're kind of always talking to each other. So if one is happy, the other one is happy, and vice versa. And there's lots of different paths of communication between the gut and the brain. We've got the brain, obviously, the spinal cord, the nervous system, and the impact of stress and stress hormones on that interaction as well. And these signals travel back and forth, like I say, in a 2-way communication. And we understand some of these symptoms in IBS using something called the biopsychosocial response. And again, this is there's much larger focus on this in the Rome-5 criteria. So thinking about how physical, emotional, and social factors can all influence these symptoms that we see with IBS. And it's often that some of the symptoms might begin with a physiological cause. So that might be a viral illness. It might be sort of inflammation. It could be a GI condition such as IBD. And actually, some of the worry and that stress continue these symptoms on once those conditions are managed, or a viral illness has gone. And so we know that some of the physiological responses that are triggered within our body also have this influence on our immune system and the function of the gut. So probably one of the most basic examples, but a really nice example, is thinking about when you've got an exam or something really important coming up. Often people have an increased kind of need to go to the toilet, then their appetite might reduce, they might get nausea, and then they get this kind of boom bust where they become unwell as soon as that exam is over. And so this is a combination between how the gut and the brain are talking to each other, and how sort of the direction of those messages in terms of the neurotransmitters, the stress and the anxiety response, are all influencing how things are moving in the gut, essentially. But the pathophysiology of IBS is quite complex, and it's still not really understood. Some of it is probably way over my head as well, and you guys might, understand it better than me as doctors, but it involves kind of alterations in sort of our neurotransmitters, intestinal microbiota imbalances, visceral hypersensitivity. It's changes in our gut barrier function, which can impact the motility, and then the response to stress as well. And we know that sort of interruptions in these is where we then see some of those symptoms that are associated with IBS. So one of the key ways that we can understand some of these symptoms that we're seeing in our patients, as I've mentioned, is using the biopsychosocial model. And as I said, this is reflected in the new Rome 5 criteria. And this is a combination of how biological, psychological, and social sort of elements can be a contributing factor and all interlink to help us understand why those symptoms are occurring. So it might be that there's a biological trigger, so an altered gut microbiota, or a dysregulated motility for a patient. But there's also some stress. For example, exams are coming up, the family have moved countries, or the parents are going through divorce. And then you've got your social aspects, so your relationships, the environment in which these families are in. And it's that link between all of those that can help unpick some of these symptoms and manage them better for children. We also know that some early life events can have an impact, particularly on sort of abdominal pain disorders. So, things like your genetic predisposition, those early life psychological events, like parenting, abuse, family stress, all of those things over childhood actually have been shown to increase risks of sort of functional abdominal pain disorders as children get older. So because IBS is likely a result of a number of different interactions, so your biological, your psychological, and your social, actually often what we need is a multidisciplinary or a multimodal plan to manage these symptoms. Normally something in isolation, so whether that's diet, whether that's medication, or whether that's psychology, is not enough to kind of manage what is happening for these children. And so psychology involvement might be sort of gut-directed hypnotherapy, which you've got really good evidence for. You've got cognitive behavioral therapy. You've got our pharmacological therapies like laxatives for the children with IBS-C, antispasmodics if sort of abdominal pain and cramping is a big issue. And then we've got neuromodulators that we might use as well. And then, of course, there's diet. I'm a dietitian, and this would be the thing that I would be sort of advising on and thinking about. So we will get onto the low FODMAP diet because that is obviously the reason for this webinar today. But I just want to flag that this isn't actually the first line dietary treatment that we should be advising in IBS. It's quite a difficult diet to adhere to. There's not that many pediatric dietitians trained in doing the low FODMAP diet. And actually, there might be some things that you can try first. That doesn't mean that it needs to be quite as restrictive. So this is taken from the NICE and the BDA guidelines for management of IBS. It is based on sort of adults, but actually the majority of the literature we have, more good, robust literature we have anyway, around management of IBS is in the adult population. And so we should be recommending kind of eating regularly. So that's a breakfast, lunch, dinner. And this is really important for, sort of normal motility of the gut. If you've got someone who's constipated and they're skipping meals for a long period of times, we're not triggering any of that sort of gastrocolic reflex, which is hopefully going to help with kind of moving things along the gut. So first of all, eating regularly and trying not to skip meals. Trying to aim for a balanced diet. So we want a plate to be around 50% of our energy from carbohydrates, 35% from fat, and 15% from protein. And we need to make sure that that's of good quality, so it does have fiber. Of course, you could have a diet that had chicken nuggets, some chips, and a little bit of tinned vegetables on it. But we want to also be making sure this is whole food, full of sort of variety of different types of fibers to support the gut in general. Making sure our children are well hydrated. We don't need to overhydrate. We just need to aim for requirements for age. But obviously that's important for motility of the gut. If they're constipated, keeping the stools in a softer form. And then avoiding those kind of obvious trigger foods. So often things like chocolate can be quite problematic, carbonated drinks, really spicy food, and garlic and onion in particular can be a problem. Then we need to think about sort of their lifestyle advice. So are they physically active, getting up, moving around? They got good sweet sleep quality so that they're not on their phones, just before going to bed. We know that blue light impacts our sleep ability, and sleep is linked to your circadian rhythm, which can impact kind of how the gut is moving. Need to manage any stress. So for teenagers, I might use apps like Calm or Headspace, which are really nice mindfulness apps, which they can kind of practice every day. And then obviously encouraging healthy toileting routine and taking advantage of that gastrocolic reflex, to making sure that they're kind of listening to their gut and going to the toilet as and when they need to. What about the Muse-free diet? So that's a milk, egg, wheat, soya-free diet for anyone who's not familiar with it. And this is often recommended in pediatric patients. Often a lot of the data we have, particularly around sort of just eosinophilic GI disease, is using a 4-food exclusion diet of the Muse-free diet. But there's not really much evidence in IBS for using this diet. There are components of the Muse-free diet which potentially are higher in FODMAPs, which might explain why some children get some benefit when they go on this. But from the literature, I've done a search and I can't find anything. So it wouldn't be a first-line diet that I would be using in children with possible IBS or suspected IBS. So if the first-line advice doesn't help symptoms, doesn't resolve those symptoms, we have the low FODMAP diet as a consideration for a type of dietary elimination we can do in these patients. And it's actually the most common used non-pharmacological treatment for IBS. And essentially it involves taking out these short chain carbohydrates that are poorly absorbed and are highly fermentable. And so FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So a little bit of a mouthful. And actually what we see in these patients is that the FODMAPs are poorly absorbed in the gut. So that means that they kind of pour water into the small intestines, which can cause distension, and then move through into the large bowel where the bacteria readily feed on them and ferment, causing bloating, distension, maybe flatulence, abdominal pain, and then constipation or diarrhea, depending most likely on the type of FODMAP that a patient is sensitive to. So there are different types of FODMAPs, and not all of them kind of trigger the same symptoms in the gut. You've got our fructans and our GOS, so our galacto-oligosaccharides. These are not digested by anyone in the small intestine, but what happens is the sugar passes into the large intestines where the gut bacteria ferments on it, producing lots of gas. And this gas causes intestinal distension, causing wind, But for those with IBS and who have a highly sensitive gut, this can cause problems kind of motility regulation, bloating, abdominal pain, discomfort, and this altered bowel habit. Often with the fructans and the GOS, you see much more sort of the bloating, constipation type symptoms, whereas with the sorbitol, the mannitol, and the fructose, these tend to have more of a sort of osmotic impact on the gut because they're absorbed slowly along the length of the small bowel. And so they attract the water, causing the intestines to distend. And then if they're not fully reabsorbed not fully absorbed in the small bowel, again, they move through into the large bowel where the bacteria ferments, producing this gas, causing the pain, discomfort, and the altered bowel habits, which tend to be more of the sort of looser stools, diarrhea type picture. And then we've got our lactose, which we need lactase to break down, so the enzyme. And again, this has the osmotic impact in the gut, so it pulls the water in, can trigger sort of looser texture stools, but that bacteria then also ferments the lactose, causing the gas, the pain, and bloating that we often see with sort of more of a lactose type issue. So there's both kind of acute and chronic impacts of the low FODMAP diet. And I've obviously gone through some of those acute impacts just whilst they're being eaten at the time. So the osmotic effect of certain FODMAPs that accelerate sort of the gastrointestinal transit time, cause colonic distension. Then we've got the fermentation of the bacteria, so that produces the gas, but also produces the short chain fatty acids, which we know are beneficial. But this does cause this luminal pH drop, which can impact the microbial composition. And so this might impact the type of bacteria that are in the gut over time. And so over time, this can lead to increased kind of abundance of those gram-negative bacteria that can have an impact on sort of the barrier loss and this visceral hypersensitivity, which we know is a big issue in patients with IBS. But what does the traditional sort of low FODMAP diet look like? So this was first kind of developed or, studied by Monash University in Australia. And typically it's made up of three kind of distinct phases. You've got our phase 1, which is our FODMAP restriction. And this usually involves kind of reducing the very, very high FODMAP foods and replacing them with suitable alternatives. So we want to make sure that we're not just cutting fiber and things that are going to look after the bacteria in the gut out of a patient's diet. So we need to replace those with alternatives that are low in FODMAP, that still means the child or the patient is getting enough fiber, enough nutrients, enough calories, etc., to be able to grow. And this is normally followed for as long as it takes for those symptoms response to occur. So in practice, that's usually between 4 and 6 weeks. But some people might be a bit longer, or some people we might do a little bit shorter. And how do we know kind of which foods are higher in FODMAP? So like I said, it was the Monash team that initially kind of established kind of what the FODMAP content was of different foods. And they did this through various different sort of sampling measures and set cutoffs to what we consider to be sort of a high FODMAP food in terms of your lactose, your mannitol, your sorbitol, fructans, etc. And you can see here a really nice table that they produced that show us our higher FODMAP foods. Obviously, that's not every single food, but some of the main ones that are prevalent in people's diets, and then some lower FODMAP alternatives that we can use. But it is also important to kind of notice or be aware that actually there can be a number of different factors that can impact the FODMAP composition of food. So how ripe a fruit or vegetable is, for example, how long it's been stored for, the temperature at which it's been stored, the variety of the food, and actually the seasonal climate. And there can also be different levels of FODMAP within the same food. So for example, in a spring onion, the bulb has a higher FODMAP content than the green leafy top part. So when we're kind of advising patients about removing or manipulating their diet to manage the FODMAP components, as a dietitian, we might be recommending you can have the top green leafy bit, but we need to avoid the bottom bit, or we can use a green banana rather than a ripe banana, for example. This is just taken from the ESPGHAN guidelines. So again, they've got a really nice table that show you kind of those foods that have a higher FODMAP and some possible alternatives that could be used, and also thinking about some of those nutritional risks that could be associated with taking these foods out of the diet. Once you've done your elimination phase, we then go on to phase 2, which is our reintroduction phase. So this is a screenshot of the Monash app. This is something we use with our patients to guide them through kind of reintroduction and elimination stage of the low FODMAP diet. And this is essentially putting in a type of FODMAP at a time to see if symptoms occur. And the process is normally that we keep the diet low FODMAP in the background, and we pick a group that we want to try. So if we want to try lactose, for example, we'd keep everything else in the background really low in FODMAP. And then over a 3-day period, we'd increase the portion of that FODMAP containing food to see when trigger symptoms occurred and what those symptoms were. This would be tracked over time. Once that challenge has been completed over a 3-day period, we'd then do a washout period for probably 3 to 4 days, depending on how the patient is responding, put the diet back to low FODMAP in that time, and then pick a different FODMAP group and put that in. So we're trying each FODMAP group one at a time, but you only need to pick one FODMAP containing food from each of those groups to do the challenge to confirm whether sorbitol is an issue, lactose, mannitol, whichever it is, over time. So the reintroduction process can take a very long time, and I've got a case study towards the end if we've got time where we can kind of look at how kind of involved that really is. But once you've done that, the next step is our personalization phase. So this is essentially trying to figure out, once you've identified which FODMAPs are a trigger for your patient, how much they can keep in their diet and personalize their diet to their exact needs. So it might be that they can have a little bit of onion every single day, but if they had huge amounts, then that would be where they get symptoms. And what we should also be telling our patients is that, you know, FODMAP tolerance can change over time. So often in times of stress, your sort of threshold for being triggered by some of these FODMAPs is lower. And so you might need to pull back on some of them during sort of exams or a stressful experience. But also you might have improvements over time. So if you complete the challenge at the reintroduction phase, but actually they don't manage to tolerate that food, you can retry again in 3 to 6 months' time, because it's likely that this might have changed over time. Discuss about there being normal symptoms. We do all get bloating. We all do get a little bit of flatulence, and this is part of a healthy gut and a healthy bowel. And actually making patients aware of that can be really helpful, not to label every food as an issue for them as they bring them back into the diet. As I've said, stress makes things worse. So encouraging the use of, if you've got psychology, that's ideal. But if not, things like your mindfulness apps or breathing exercises, these can all help kind of during the reintroduction phase, particularly as it's often very anxiety provoking for patients if they've been pain-free and we're asking them to put foods back in that they feel have caused issues in the past. And we also want to encourage making sure there's enough prebiotic foods in the diet, so we can encourage these beneficial bacteria that we know are prevalent in the gut to thrive. So some of the lower FODMAP options are things like oats, firm banana, aubergine, kiwi. So these often don't trigger symptoms, but they're actually very beneficial from a prebiotic fiber perspective. For everyone, the low FODMAP diet, you know, should be a short-term diet that they're doing, and then can be used as a toolkit to manage their symptoms over time. As I've said, it can be really difficult to get children in particular and parents who've had a really uncomfortable child to engage to put these foods back in, but we don't want them on this restrictive diet for a prolonged period of time. In terms of the dietitian, obviously I'm going to be flying the flag for the dietitians in the room if there's anyone here, but actually we know that this diet is really, really tricky to follow. And there's data suggesting that actually compliance is significantly better when there's a dietitian involved. So phase 2, that's a reintroduction phase. There was a 70% compliance with a dietitian involved compared to a 39% without a dietitian. And then sort of that personalization stage of the diet, again, around a 65% improved compliance and outcomes compared to no dietitian, which was only 29%. So this is just a little bit of a look at kind of the evolution of the low FODMAP diet over time. I'm not going to go through each of these studies in detail. They're all there if it is something that you would like to have a little look at. But we started back in the sort of the 2000s when there was kind of this early observation that these fermentable carbohydrates seemed to worsen symptoms for patients, and actually removal of them helped with some of those symptoms. And over time, that has changed. And there's been more and more pediatric research done, although not huge amounts and not, big RCTs or anything like that. But we're now seeing that actually that it's beneficial in adults, but we're seeing some benefits in children as well. But what we're also seeing in the low FODMAP diet is that this initial blanket exclusion of all high FODMAP diets isn't probably necessary. And actually what we could do is a bit more of a targeted approach, particularly in the pediatric patient, to manage those symptoms as effectively, but on a less restrictive diet. So this study in particular compared patients who had IBS, they were adult patients, I believe, who followed a low FODMAP diet, directly compared it to a high FODMAP diet. And actually what they found is that there was a better improvement in symptoms, so using the IBS symptom scoring questionnaire in patients who followed the low FODMAP diet compared to those who had the high FODMAP diet. And so when we look head to head in this patient group, there does seem to be a benefit in using this diet in particular. But what do we know about sort of pediatrics? Like I said, a lot of the evidence today is in the adult population. And so there's a number of different studies in pediatrics. A lot of them are quite small groups. They're very short. One was only sort of 48 hours. But actually what a lot of them are showing is that there's an improvement in abdominal pain. There's an improvement in symptoms in terms of toileting, so either constipation or diarrhea. And these children are seeing a benefit, but like I say, they're quite small studies. They're quite short term, so it's difficult to kind of draw concrete conclusions from them, I suppose. And there has been kind of 3 systematic reviews in pediatrics that look at using the low FODMAP diet. And actually, they all do have the same conclusion, that there's kind of insufficient evidence to support or use it in this population. So we've got all the Italian groups. They don't recommend it as a diet that we use in children. But the ESPGHAN guidelines say that it can be considered in carefully selected children with IBS. And so it would be those children who are at low risk of sort of eating disorders, who don't have, like ARFID or very sensory type eatings, who have a healthy weight. They're not at risk of becoming nutritionally compromised by doing this diet. And it's also, they do stipulate in the ESPGHAN guidelines that they should have access to a qualified pediatric dietitian. So this is just sort of a snip of the ESPGHAN position paper for the use of the low FODMAP diet in pediatric gastroenterology. There's a QR code there to have a read if you haven't seen it before. But essentially, this algorithm sort of demonstrates how we would make the assessment and the diagnosis of IBS, thinking about when to refer to a dietitian, and how we might go about starting the low FODMAP diet in this patient group. There are, of course, some limitations to the low FODMAP diet, as there are with, the majority of treatments that we'll use within gastroenterology or dietary treatments that are available to us. So it can be quite costly, particularly if we're encouraging families to maybe move away from, vegetables and things that kind of make up quite a big part of their diet. So garlic and onion are relatively cheap, but we're suggesting move over to like a garlic infused oil, for example. It's a little bit more costly for them, so it can have an implication for the family. It's quite complex to follow, and so it can take a little while for them to kind of get their head around it. It's quite time consuming, particularly at the beginning, sort of adapting recipes, getting used to what's a high FODMAP food and what's not. Access to professionals can be really tricky. Like I've already said, there's not that many pediatric trained FODMAP dietitians. And so it can be quite hard to get the support from the people that you need. There's a risk that we're going to impact sort of micronutrient intake as well as macronutrient intake, and it might not be suitable for all patients. So if there's a flavor of an eating disorder emerging for a patient, if they have ARFID or very specific sensory dietary requirements, then it can be really tricky to follow this low FODMAP diet. I don't know if you can hear that, but there's a big storm going on in the UK if you're not here. In terms of risk of nutritional deficiencies, and so with any exclusion diet or dietary manipulation, there is, of course, a risk of nutritional deficiencies. And actually, the low FODMAP diet requires substantial substitutions of foods, and that's where it can be quite tricky. In terms of the data that we have for pediatrics, there's not much about nutritional adequacy of the low FODMAP diet. Found this paper that was looking specifically at a group of children with ASD who were also put on a low FODMAP diet. And they identified that they had a slightly lower intake of B12 when they followed the low FODMAP diet, and a lower sodium and folate intake. Some of that might be that, potentially some ASD children will have a higher intake of sort of your ultra processed foods. And so actually the sodium reduction might have been a change up in those. In adults, we have seen that a short-term exclusion of FODMAPs does lower total carbohydrate intake. It can lower the calcium intake, obviously, particularly if you're targeting lactose as an issue. There's a lower total energy intake. And a lower intake of fat and proteins. The total intake of fat and proteins wasn't any different than controls. So there's this potential short-term change in the nutritional profile of patients when they're following the low FODMAP diet. But there is some evidence to suggest that actually using a dietitian when doing the low FODMAP diet can improve the quality of a child's diet. So this was based on a US study, where children aged sort of 7 to 13 who had functional abdominal pain were classified as having a poor diet quality, essentially, on their initial assessment. So they had less than the recommended intake of fruits, veggies, grains, dairy, and a variety of different micronutrients. They then went on to a sort of a 3-week dietitian-led low FODMAP diet. And what the outcome showed is that they all had a reduction in their FODMAP intake, which is great because that was the idea of the low FODMAP diet. They actually increased their intake of B6, vitamin C, and vitamin E, and improved their servings of vegetables and protein, and had an overall decreased intake of refined grains, sweets, ultra processed foods, all of those things that we wanted to keep to a minimum. So it might actually be beneficial to do a low FODMAP diet if you're using a dietitian to support you to do that. The other concern that's often raised is the impact the low FODMAP diet has on the microbiome. So many of the higher FODMAP foods are also high in prebiotics, so onion, garlic, asparagus, apple leeks, various pulses, chicory and inulin. But actually, does removing them from the diet impact the microbiome in the short term or in the longer term? As I said, this diet should be a short-term diet. So ultimately, those long-term implications should only be an issue if the patient is following on this diet for longer than we would recommend. So this is a study that looked at the impact of the low FODMAP diet on the gut microbiota regulation. So it was a systematic review and a meta-analysis. And this involved 10 RCTs, so nearly 600 patients. And what they showed is that the low FODMAP diet actually showed a significant positive impact on the intestinal flora compared to a normal diet. There wasn't much detail about what the normal diet was. So again, it might have been that whoever was supporting with this had managed to increase some of that plant-based diversity by using low FODMAP options. But actually, the analysis revealed no significant difference between the microbiota of those with a low FODMAP diet and a normal diet. And so I'd mentioned before about the traditional kind of approach to the low FODMAP diet, where we would do a top-down approach. We take out all of these high FODMAP foods first, monitor for response, re-challenge the FODMAP groups, and identify the dietary triggers. Actually, the advice is kind of being tipped on its head a little bit now, which we've seen similarly in sort of EOE management. We used to go in with a 6-food exclusion diet. We now go in with a 1 or a 2 food. So actually, we can do that approach in IBS as well, where we identify based on their clinical presentation, so the symptoms that they're getting, also what their diet is, and target those FODMAPs from the start and just take out a couple of them and see how they respond to it, and then either take out more or pull back depending on how the symptoms are. And this can mean a less restrictive diet. It's less difficult for the patients to follow. And so we tend to, in pediatrics or in my practice, we use a bottom-up approach by targeting specific FODMAPs from the very beginning. And that's because not all FODMAPs are created equal. So this is a really nice study looking at patients with IBS and which FODMAP groups triggered their symptoms. And they looked at fructose, lactose, fructans, GOS and polyols. And actually what they found is that fructans and galacto-oligosaccharides, or the GOS, were the most likely FODMAP group to trigger IBS symptoms. So that's symptoms of abdominal pain and bloating. And actually, we know that abdominal pain is one of the most common sort of presentations that we see in clinic. And so those might include veggies like Brussels sprouts, cabbage, pumpkins, etc., various different legumes, different seeds and nuts. And actually, we can probably use certain sort of targeted approach by just taking out fructans and GOS to start with in this patient group, rather than going the full hog and doing a full low FODMAP diet. This is another study back in 2024 that looked at the simplified or less restrictive low FODMAP diet compared to a sort of a standard low FODMAP diet. Again, this is based on an adult population because that's the data we have. And they did a simplified diet that looked just at fructans, GOS, and lactose, compared it to a traditional low FODMAP diet where we took out all of the low FODMAP groups. And actually, what they found is that the FODMAP simple restriction, so the FODMAP light, we might call it, led to similar reductions in key symptoms of IBS. So abdominal pain improved very similarly to that as a traditional low FODMAP diet, bloating and discomfort all had a very similar improvement profile compared to traditional. The stool consistency was actually slightly better on the low FODMAP diet, but I suppose it depends on how the patient is presenting and what outcome it is that you're trying to achieve by manipulating their diet. And they concluded that the low FODMAP diet, the simple one, seemed to be better tolerated compared to the traditional low FODMAP diet. They had fewer dropouts in their study group because the side effects and the difficulties were not as problematic as the traditional low FODMAP diet. So we want to target those symptoms. So we need to think about sort of the presentation. So fast colonic transit, sort of long-standing diarrhea. We probably want to target more of those osmotically active FODMAPs, so our fructose and polyols. We could consider some other dietary interventions, like adding in sort of a gel-forming fiber, like a psyllium husk, for example. And if they've got excess wind, bloating, and pain, we might want to target more of the FODMAPs that readily ferment. So reducing some of these oligosaccharides in the diet might be your starting point in more of a targeted FODMAP diet. What if there's no response to the low FODMAP diet? There are some other considerations. So we need to check compliance. So are they following the advice? Are there any of these FODMAP foods sneaking in? So maybe at school, if they grab some lunch somewhere, any sort of convenience type foods, or cereal bars, things like that often have inulin and things that people don't realize are there. Thinking about other parts of the diet, so the fat consumption, so taking a diet history to check the dietary fat component, and this is because a significant intake of fat in one meal can worsen sort of GI symptoms, so maybe spreading that out throughout the day. Thinking about different cooking techniques. Are they frying everything? Can we grill it instead? Thinking about the different types of fat as well. Remember, we're not going for a low-fat diet. That's definitely not what we're going for. We need to make sure they've got adequate calories, essential fatty acids, these fat-soluble vitamins, if you are manipulating fat in the diet. For the teenagers or, young adults, we'd be thinking about caffeine intake as well. We know this is stimulant. So assessing the individual diet history and symptoms is really important. And then obviously ensuring adequate fluid intake. Is there other considerations we should be having with a non-response to a low FODMAP diet? So potentially small bowel bacterial overgrowth, thinking about whether disaccharide deficiencies, and potentially in these teenage girls, whether endometriosis could be a contributing factor. So I've got a few take-home messages, and I do have some case studies if we have time. But just to take home, the low FODMAP diet is effective at reducing symptoms of IBS in patients who are pediatric patients. We shouldn't be using it as our first-line dietary therapy, and we should only be using it in the short term. Although we can see that it's effective, it's not kind of recommended in the guidelines, apart from in ESPGHAN, depending if you have the correct support and it's the appropriate patient to be doing it in. The FODMAP light could be considered as effective as the traditional low FODMAP diet. It might be easier to follow, and in my view, it's a better approach in a pediatric patient. And we should always be doing this with support of a trained pediatric dietitian. So Mara, do you think we have time to quickly go through some case studies?
Yes, I think we have a bit of time. So
yeah. So I'm gonna just have a chat about Tammy. This is obviously not her real name, but she was a 14-year-old girl who we saw in clinic who had a long-standing history of abdominal pain and diarrhea. She was growing well, so weight and height on the 50th centile. She'd been prescribed mebeverine. There's quite a complex family history in terms of dad having Crohn's disease and UC. He'd had kind of lots of issues with, prolonged episodes of rectal bleeding and missing lots of work. So there's quite a lot of anxiety around gut-related symptoms in the family. She also had an older brother who was under a different centre for sort of GI issues as well. And she had her IBS symptom score completed when she came to our dietitian-led FODMAP clinic. And she had severe abdominal pain daily. She had bloating every day, but she said it was manageable. She had watery or porridge-like texture stools, where she was opening her bowels up to 3 times a day, but it was always associated with urgency. And she felt like she was never kind of fully evacuating her bowels properly. She was a bit of a fussy eater, but she had an unrestricted diet. Her school attendance was down at 50%. And the family reported that they weren't able to go on holiday or days out in case Tammy needed the toilet. So they were really kind of isolated to their home. She'd had some investigations because the family history of IBD, so her OGD was normal. She'd had a gastric emptying study, which was normal. She'd had abdominal x-ray, and that was normal. I didn't put there, but she'd also had various stool tests like elastase, etc., which were all normal. She'd tried a mousse-free diet before, and she hadn't had any response to that. And Mum just mentioned that Calpol, which is like a suspension paracetamol used in children in the UK, had actually made her symptoms worse rather than making better. And that is suspended in a syrup, essentially. So we went through and did her diet history. So as you can see, she's probably got a typical teenage diet for the UK. It might be different depending on where you are in the world, but this is pretty standard of what we would see. Lots of processed foods, lots of snacking on convenience types foods, and not that much fruits and veg. So I don't know how easy it is to respond to this, but if you can pop it in the chat. Can you name any high FODMAP foods that might be present in her diet already? So I'll just go back a slide to see.
So you can write in the chat box.
I can't actually see the chat, but
garlic and the garlic bread. Says someone. Mango.
Yeah.
Wheat. Broccoli.
Yeah. So she's got a few FODMAPs kind of creeping in there. And then, are there any micronutrients that you can identify might be lacking in Tammy's diet? So is there any vitamins, minerals, like what's her fiber intake like? Anything that you might notice about her diet? I'll go back again. Again, just pop it in the chat there.
Folic acid, iron.
Yeah, she doesn't have the greatest diet, does she?
Vitamin A, C.
Yeah, she's not doing great. Okay, fine. So what we did in clinic is we actually went for a full low FODMAP diet because she'd have had such long-standing symptoms. The family were really, really motivated. I started an A to Z multivitamin just to cover her for everything, just because she was quite fussy with what she would and wouldn't accept. And I just felt that it was safer for us to do that. I made sure she was getting enough calcium. She didn't really like dairy other than a little bit of cheese. So we started a calcium supplement, which obviously has some vitamin D in it. We started a fiber supplement, so a partially hydrolyzed guar gum, as her diet was low in fiber. And then I asked her to download something called Nerva, which is an app specifically for gut-directed hypnotherapy. And then we did some specific changes. So her garlic bread was changed to sourdough with a shop-bought garlic-infused oil. And that's important that we're not just buying oil and dumping garlic cloves in it, because you're still getting the FODMAPs because they leach out into the garlic, into the oil. We changed her onion to the green tips of her spring onion, or an aphrodida powder, which is an Indian spice that has quite an oniony taste to it. Switched her watermelon to cantaloupe melon, changed her mango to pineapple, went for lactose free. opted for naturally lactose-free products like rice, potato. If she was having convenience food, we'd use a sort of a gluten-free one. Change the broccoli to the florets only because the top has a lower FODMAP content than the stalk, and then changed her honey to anything with maple syrup. And we use the Monash app, which is what those pictures of the phones are there, to help her kind of get more confident which foods had a higher FODMAP component and which didn't. I just wanted to quickly talk about gut-directed hypnotherapy and why we recommended it, although obviously I'm not a psychologist. But we know that there's some really wonderful improvements in symptoms of children and adults that follow gut-directed hypnotherapy, and that's both in-person treatment with a psychologist, but actually also through sort of apps and online learning for that. So this study just sort of demonstrates that. So if you have a time, have a little look through it. Like I say, I often use an app called Nerva with my teenage patients, so they can do some self-directed, gut-directed hypnotherapy. So we had our first follow-up. She had no abdominal pain anymore. She'd only had 3 episodes since we'd started the low FODMAP diet previously. Her distension had improved completely. She described her bowels as a normal texture stool. They were no longer watery or mushy. She was attending school, and there was a much improved quality of life. So we started the low FODMAP introduction, but I will caveat that with she also had quite a substantial amount of weight loss, which wasn't ideal. So we'd suggested to start the low FODMAP reintroduction, well, not to reintroduce, just to go back to the previous diet, but the family didn't want to do that. They wanted to go through the process of finding out what the trigger was. She'd actually had quite a lot of exam stress and sort of socials issues in the family, so we thought that might be a contributing factor. We had reduced all her simple sugars and carbohydrates because she was having less of these convenience type foods. She'd also returned to football. She was quite a keen football player, and actually so she'd had an increased energy expenditure. So we started some ONS on her football days. They were clinically lactose free, so low in FODMAPs, and we gave some basic advice around food fortification as well. So we did start the low FODMAP introduction. Is there any one that you might think about introducing first, or would you go by what the family wanted to do? I can't see what's being written, so I'll just say you go by what the family want. Yeah. So in terms of the reintroduction process, as I've said, we tend to do one low FODMAP group at a time. We used for this patient the Monash app to do that. You can download it on the App Store, Google Play, or Amazon. And it tells you the portions that you need to reintroduce, and you can also track symptoms. So that can be really, really helpful, particularly in the teenagers. They like an app. It gets them engaged in following the advice. And so this was her response. It took a long time to reintroduce all of the foods. And some of them were tolerated, and some she had mild symptoms with. And so what we did in our final appointment is that we confirmed that sorbitol and fructose were her main triggers. And so she keeps those to a minimum in her diet and doesn't really have them anymore. She's just doing her A levels now, I believe. So she is using the low FODMAP diet as a toolkit because it's more stressful. So she's kind of gone back to the low FODMAP diet. But she's now playing at a high level women's football, and she plays regularly and doing really well. So she had a really good response. The weight loss in the middle wasn't ideal, but she regained that weight, and actually she's doing really well at the moment. I have one more case study, but again, I'm over time, so I don't know if you want me to skip this or not.
So I think we can also take some of the questions
Questions?
if you
Yeah,
like. Yes.
fine.
So someone asked if during the reintroduction, how many times should we expose the moderate high FODMAP food to establish it's not tolerated?
Yeah, good question. So, like I say, we increase over 3 days usually. If they get a symptom at some point, normally what I would do is kind of say, well, let's take it back out, do a washout period, and just try it again to see if actually it was something else that was going on, and whether this is repeatable. If it happens kind of a second time, I'd probably say actually that FODMAP at the moment isn't tolerated. We can re-challenge again in 3 months or 6 months' time.
And also, how much time should we look out for symptoms once they ate that food?
So usually it's quite quick. So the guidelines or the recommended reintroduction is every day we reintroduce the food. So because the food is fermented quickly as you eat it, you normally get those symptoms within the same day or 12 hours. So it should be fine to just increase each day as it comes. If your patient has a history of it being a bit more of a delayed response, then you might leave a day in between before increasing it up. But it would be very much based on their history, suggesting that you might do that approach.
You also mentioned that it's like you should use the low FODMAP diet for short periods of time, short meaning like 4 weeks or more than four
Yeah.
weeks.
So the strict low FODMAP diet, or any FODMAP manipulation, I would do for as in the sort of stage one, I do for sort of 4 to 6 weeks as a maximum, and then you're obviously reintroducing. So you do keep the diet low FODMAP in the background whilst you're challenging. So they are on it a bit longer, but probably by the end of the process, it's about 12 weeks, and they should be then on their personalized diet and kind of ready to kind of leave the clinic and manage their symptoms using some of those toolkits that they've developed.
Super. So I think that we can do the last case, and if
Yeah,
you want, like
I'll,
yes.
I'll whiz through it really quickly. So this is actually I was a private patient of mine, not an NHS patient. But this was an email that I got from mum just last week. Actually, I feel as a male teenager at secondary school, too many assumptions were made along the way that he didn't want to be at school and that he was anxious. At no point was he directed to a dietitian despite his symptoms. It took 1 year to see a gastroenterologist within an NHS setting. He sent him to a psychologist for a disorder of the gut-brain interaction, despite ongoing vomiting, reflux, bowel changes, and no investigations. We had a 5-minute conversation and then we were shooed away. And I just wanted to share that because we are definitely stretched for time in clinic, but some of these patients, that some ways that makes their symptoms worse because we're not giving them the time to kind of really divulge what is going on for them. So this is Johnny. He's a 16-year-old boy, growing really well, 84 kilos. He didn't have his height, but he was well nourished. He had quite a significant history of allergies, so he was on lots of different antihistamines. He had auto adrenaline injectors. He was on a bit of a concoction of various different multivitamins and enzymes, which were not started by me. Had high dose magnesium. This was recommended by a pediatrician because he had bad asthma, and it was being used to manage that. The mum again had UC. His older sister had lots of sort of GI issues, but no diagnosis. And there's this really strong atopic history for Johnny and his family. So as I said, he had significant eczema, particularly on his face as a baby, patches on his body. He had multiple IgE-mediated allergies. And he'd been generally well until 2016 when he'd had this fall and then developed migraines, which was later diagnosed as a post-concussion syndrome. In 24, so quite a few years later, he presented with this nocturnal vomiting. It was intermittent over 7 days, but then it resolved, and actually vomiting was kind of a sporadic issue by the time I saw him. But soon after that, he developed these kind of persistent GI symptoms, so diarrhea, abdominal pain, nausea, acid reflux. And he had really poor quality of life. He wasn't functioning at all. He, wasn't going to school at all. He was just attending online if he could manage it. He was getting diarrhea both in waking hours and at night, with varying frequencies up to 3 times at night. The stools were always loose in texture. Occasionally had some harder stools, but not really an issue for him. Had severe fatigue, brain fog, and was sleeping for hours in the day. He'd had some blood tests, had celiac testing, which was normal. Calprotectin was normal. Had some parasite screens and bacterial screens, which again were normal. H. pylori was normal. Had a diamine dioxide blood test because the family were worried about mast cell activation, again, which was normal. He'd not had any endoscopies. And again, as I said, the mum had advised that the NHS team had suggested this was a disorder of the gut-brain interaction. And so what we did is a modified low FODMAP diet. I felt like he was quite low, and actually taking significant foods out of his diet might add to some of his anxiety. We discussed about possible breath testing to rule out SIBO, depending on his response to the low FODMAP diet, particularly around his symptoms of sort of like brain fog that he was getting. I'd stopped his high dose magnesium because I thought that was impacting his bowels, causing the loose stools. We had some nutritional bloods just because the fatigue, the brain fog, and the lethargy. Ensured he had adequate calcium, and we started an L-Reuteri probiotic, so a specific strain that we know is beneficial in functional abdominal pain. And so I saw him 4 weeks later, and he'd had an improvement in his symptoms, but not a complete resolution. He'd started regurgitating food into the back of his throat, a possible sort of rumination type picture, but he had some improvements in his abdominal pain, so it was less intense, and his bowels were now smooth sausage shape. He was going just in the daytime, and his blood showed a borderline low B12 and folate. So we got a breath test done to rule out SIBO. I requested an active B12 from the GP, for as a more sensitive marker of B12 deficiency. I'd started a vitamin B12 spray just because it was borderline and he had some symptoms suggestive of B12 deficiency. We discussed some diaphragmatic breathing for this possible rumination type picture. And we'd agreed that we'd continue this modified low FODMAP diet until after the breath test, just because that would be the diet you'd be doing prior to a breath test anyway. And then he had a referral to an NHS gastroenterologist. So when he came to see me after that, he'd actually had a positive hydrogen breath test. And we got his GP to treat him with rifaximin. He'd been accepted into a local chronic fatigue service. And his previous nausea and sort of related symptoms had completely gone since he'd been treated with rifaximin, and he continued with regular bowel motions. So we did some partially hydrolyzed guar gum alongside the rifaximin for the SIBO, because there's a little bit of evidence suggests that increases the sort of the benefits between sort of lapsing with SIBO. We continued that B12 spray. We started the reintroductions of the FODMAPs using the Monash app again, and discussed about sort of regular eating patterns, particularly around education around the MMC as well. So we'd identified that sort of garlic, beans, onions were his kind of main trigger. He was now attending half days at school. He hasn't had any reoccurrence of this SIBO. Mum emailed me last week, and he's currently sitting his GCSEs. He has been diagnosed with ME and chronic fatigue, and he remains under the specialist service. And again, this is an email from Mum that I do believe that his SIBO had been picked up sooner and not taken 2.5 years, Johnny would not have missed all this time away from school. I believe that the delay in diagnosis had led to his ME, chronic fatigue syndrome, and anxiety. So I suppose I just wanted to highlight that, you know, if the low FODMAP diet doesn't work, we do need to be thinking about other conditions or other reasons that they might be getting these symptoms, and not just always labeling it as a disorder of the gut-brain interaction without potentially exploring some of these things. So yeah, thank you for listening, and I'm sorry I've droned on and on.
Thank you so much. It was great, and also I love the cases. Actually, someone is asking if you didn't add any probiotics after the rifaximin.
No, I didn't add any probiotics because actually his symptoms were improving and he was building up foods back in his diet. So we're aiming for more of prebiotic foods with real food rather than probiotics for now.
Super. Thank you so much. It was a great webinar. I think that we all had to learn something from this, and also we should apply many of the things you told us today, especially like with the app. I didn't know about this app.
Yeah, it's so good, the app.
Yes. Thank you so much.
Thank you so much.
Yes, and everyone is thanking you also for this great presentation. Okay. So I think this was all for today. Thank you all for participating, and see you next month for our next webinar. Thank you again for accepting our invitation.
Thank you. Bye-bye.
Bye.